My name's Francesca. I'm a junior doctor working in the NHS in the UK, and I did my Bachelor of Medicine at the University of Oxford. So I'm going to be talking today about post-operative complications. I'm not yet a qualified surgeon, so I'll try my best to answer any questions. And if there's anything I can't answer, I'm happy to send out emails or anything with answers from senior colleagues and things like that as I can, but I'll try my best. So the lecture today is on post-operative complications. We'll aim to talk for about 40 minutes about this, and then we'll have 20 minutes of questions at the end. So if you have any questions, feel free to put them in the chat or save them to the end, and we'll have a discussion. So the next slide is about just a bit of an introduction to post-operative complications. So as a junior doctor, post-operative complications, a lot of them can be predicted. So it's important that all the members of the team plan pre-operatively in either the outpatient department, if it's a planned surgery, or on admission, if it's a more urgent surgery, to avoid these complications as much as possible, because prevention is always better than cure in medicine. And with the post-operative complications I'll discuss, a lot of them are preventable and are treatable if we recognise them early. So it's a really good topic to know about, especially as a junior, because you can do quite a lot yourself, even if you haven't got the skills to do the full surgery yourself. So on the next slide, so there's some different categories of causes for post-operative complications that we can start to think about in this lecture. So we've got factors that are to do with the patient themselves. So some things that we might come across, like patients who are malnourished, either because they can't afford food or because they've got conditions that mean that they don't retain nutrition well. I think the slides just slipped to the end. Oh, there we go. Perfect. So other patient factors include, for example, if a patient has diabetes, if they're on blood thinners, and these are all things that are to do with patient pre-existing conditions that we'll know about. And it's really useful for us to, as a surgical team, to highlight these and plan for them. So, for example, if a person is malnourished and they're undergoing a big operation, which is a big stress on the body, you can do things like pre-nutrition. In the UK, I'm not sure how it is internationally, but in the UK, we use something called TPN, which is total parenteral nutrition, which is basically where we replace 100% of nutrition into the veins. And it can help build up people who are malnourished prior to surgery. We often have people on TPN for a week or two before surgery so that they are at their full strength when they undergo big and stressful surgical procedures. Similarly, if people are likely to lose blood because they're on blood thinners, there are things. So in the UK, we have some people on warfarin. You can give things like vitamin K to reverse the acts of warfarin so that the blood's not quite so thin and it clots better, reducing the chance of bleeds. And it's just important for the anaesthetic and the surgical teams to be aware of the patient factors. And that's something really important that we can do as juniors when we're clerking people, admitting them into hospital, making sure we take a really good history of possible risk factors for post-operative complications. So it's a really good thing to be aware of. And then anaesthetic factors, this I'll touch on a bit more later, but it's things to do with the different anaesthetic agents. Certain anaesthetic agents are more likely to give nausea post-operatively, and also the actual physical act of putting a tube into someone's, basically their mouth and their throat, can cause local trauma. So if any of you have ever seen anaesthetists working, they'll often ask patients if they've got false teeth or dental implants, which could be knocked out by a tube going in, be choked on. And then there's surgical factors. So, for example, if it's a big abdominal surgery with likely peritoneal soiling, if it's likely that there's going to be an abscess with lots of pus or bowel contents that's quite corrosive being released into the intra-abdominal cavity, then those are factors that we definitely want to be aware of and thinking about, because that's something that's much more likely to cause infection and post-operative ileus in our patients. So it's useful for the team to be aware of these and thinking about these. And then post-op care factors, I'll go into a bit more later in the lecture. So the next slide's about classification of post-operative complications. So there's a couple of different ways. I found when I was learning for medical school, thinking of things in categories really helped me to remember things. So there's a couple of different ways of categorizing our post-operative complications. We can think about the timing of the complications, so immediate, early and late, after, during and after the surgery. You can classify them by severity, so complications that are not so severe or complications that drastically affect the prognosis of our patients. You can categorize them by the system affected, so if it's a complication affecting the urinary system, the CNS system, or any other system of the body. You can categorize them by cause, and that can link back to our patient factors, anesthetic factors that we talked about before. You can also classify them to do with the impact and the outcome for the patient, or you can be sort of general or specific to the surgeries. So this lecture that I'm giving is about general post-operative complications. I'm not going to touch on specific surgeries because that would be too long, and you'd need multiple different lectures from different specialists for that. But these are general things that after any surgery, a patient might be at risk of. So the next slide is about the categories that I find the most helpful. So when I'm thinking about post-operative complications, I like to think of them in terms of the timing, because as a junior doctor, this is a really practical way of thinking about complications and diagnosing or trying to work out what we think might be going on, because often you'll have a person on the ward who starts to deteriorate after a surgery, and if the surgeon's busy in theatre, it's up to you to try and work out if it's urgent, what might be going on, and the initial management. So having a bit of an idea of what different complications can happen at what different times can be really, really useful to think of your differentials in your head so that you can approach your seniors with a systematic way of thinking, and some useful differentials for early management. So we've got the immediate complications. So these are things that usually happen during the operation. So what the first thing I mentioned is oropharyngeal trauma during intubation. So that was what I mentioned previously, where anaesthetists will often ask about false teeth and things like that. But equally, even if you don't have any risk factors, the process of intubation can be traumatic, and can lead to just intrinsic damage to the mouth and the pharynx or pharynx. So surgical trauma to local structures, this obviously is very dependent on exactly what the surgery is and where it's located in the body. But as we know, even when doing the most simple of surgeries, it's easy to damage surrounding structures with our instruments or things by accident. And so that's a really common intraoperative complication. And then we've got primary hemorrhages. So these are, for example, during the operation, if the surgeon accidentally ligates a blood vessel and they have a bleed during the operation, that's called a primary hemorrhage. I'll go into hemorrhage in a bit more detail, but this usually intraoperative hemorrhage should be fixed by the surgical team involved in the operation itself. It's not something that a patient would be closed up with that going on inside, if that makes sense. So the most useful sort of ones to think about, I think, as a junior doctor in surgery, is the early complications. These happen from around 1 day after surgery to 1 month after surgery. And these are the typical patients that we'll be looking after on the wards, who've had various different surgeries of different kinds. And it's up to us to recognise the signs of these different complications. So the first one I've got on the list here is secondary hemorrhage. As I mentioned, I'll talk a little bit more about hemorrhage later and how to recognize it in management, so I won't go into it here. The second one on the list is VTE, which stands for venous thromboembolism. And that's a very common complication where basically, because of stasis of the blood when a patient is immobile, so on bed rest, typically they're not moving their legs much, they're not moving much at all because of pain, because of the anaesthetic, and various reasons. And particularly in our more elderly patient cohort, they're more at risk of these. And it's when a blood clot forms in the deep venous system of the legs, that's known as a DVT, deep vein thrombosis, and that can dislodge and cause a VTE anywhere in the body. And particularly we think about it in the lungs with a pulmonary embolism, or otherwise dislocating and ending up somewhere in the brain or things like that, but I think that's a lot more rare. So for these sorts of patients, you might see them developing fevers, and then when you go and examine them, you can't find an infective cause of the fever, but perhaps they'll have some calf tenderness. One of their calves might be more swollen and red than the other one. And that's when you really want to start to think about DVT, deep venous thrombosis, and you want to make sure you're treating them. So in the UK, we have everyone over the age of 16 who comes into hospital has DVT prophylaxis. So we basically fill in a questionnaire that goes through the risk factors for clotting. And if people are likely to be immobile for a long time, they receive basically anticoagulant medication. And often they receive, if they don't have vascular pathology, they receive tight compression stockings on their legs to help reduce the risk of deep venous thrombosis. The next one in the list is urinary retention, which is a bit more easy to understand. So often after surgery, particularly abdominal surgeries and things like that, people will go into urinary retention. It's really important to think about because it can cause a lot of discomfort for people, and especially elderly people can cause them to go into delirium and acute confusional states. So as a junior doctor, if you can recognize urinary retention, and it's very easily treated with catheterization, which is something that we can all do as juniors. And it's really satisfying if you relieve someone of that discomfort, and it's a very simple procedure. The next one is atelectasis and pneumonia. So these are secondary chest infections as a result of the anaesthetic. So when people have anaesthetic, and particularly when they have operations on their abdomen, they become very reluctant to take deep breaths because of the post-operative pain. And then the lack of ventilation to the bases of their lungs puts them at much higher risk of infections at the bases of their lungs. And these can take place anywhere from 1 day to 1 month after surgeries, and can cause a lot of problems, and if left untreated can lead to sepsis and death. So it's really important to think about. And again, as junior doctors, if you've got a stethoscope on the wall that we can use, we can listen to people's lungs. We can use chest x-rays to have a look at people's lungs. And it's another really important thing to look out for on our post-operative patients, and might be something that you wouldn't think of if someone's just gone for an abdominal surgery, that they might be at risk of a chest infection. The next one is wound infection and dehiscence. So anyone who's had any sort of surgery involving either the making of a wound or the cleaning of a wound will be at risk of infection because there's a break in the skin, which is our infection barrier. So it's really important for anyone who's post-operative to have their wound checked, either if you've got skilled nurses who can look at wounds. It's also something as junior doctors we can do. So it's really important to make sure people's dressings are clean and to check the wound site at least on a daily basis to make sure that they've got no signs of wound infection. And the last one on that list is antibiotic association colitis. So in the UK, and I'm guessing this is also the case in many countries in the world, a lot of our patients who are going for surgery receive antibiotics, either as a prophylaxis or because the surgery is particularly dirty. They receive antibiotics to prevent them from getting secondary infections. And the use of antibiotics can lead to associated colitis. So that's inflammation of the colon, which can lead to diarrhea and tummy pain, and is important to recognise. So then the late complications that occur after a month, after the person's had surgery, are important to be aware of, but I'm not going to focus them on them in this lecture, because by this point the patient will have likely gone home, and it's these late complications that may cause our surgical patients to be readmitted to hospital. But as junior doctors who are ward-based, at least in the UK, we work majority on the wards. It's the early complications that are really the focus of our job. The late complications that cause people to come back in include scarring, so that either, for example, on an abdominal surgery, scarring on the skin is not necessarily a problem, but if you've got something called adhesions inside the abdomen, so that's where sort of scar tissue forms between different parts of the bowel that have been handled during surgery. This can create problems like obstruction, and is really important to be aware of if you're ever working on a general surgery ward. It's really common, and unfortunately there's not really much we can do about that, because obviously if we reopen people for a second surgery for decompression and things, then they're at higher risk of further adhesions, because anytime we're opening the abdomen, it's likely to cause adhesions. So the second thing on the late complications is neuropathy. This can happen when we sort of damage nerves during the operations, and can lead to problems with chronic pain and things like that for our patients. In the UK, these sorts of things are managed by the senior surgical team, but it's really useful to be aware of as a junior as well. And then, of course, the third point on this list is about failure or recurrence. So obviously no surgery is 100% effective. So the problem that we were trying to fix may recur, or the operation that we were trying to do may fail for whatever reason. For example, in abdominal surgery, if we have a bowel resection and try and form an anastomosis, which is where two ends of the bowel are sewn together and a part of the bowel is removed, sometimes that anastomosis where those ends are sewn together can fail, it can degrade, you can have leaks. And there are a few things that surgeons can do in the operation to prevent this, but sometimes it's just a complication that does happen after abdominal surgery. And in those cases, it's really important to recognise those patients and take them back to theatre. I'll talk a bit more about that in a minute. So the next slide. So the first main general post-operative complication I'm going to talk about is post-operative pyrexia. So this is in the early category of post-operative complications, happens between 1 day and 1 month after surgery. And I've put in quite big letters on this slide that it's always important to think about infection and sepsis as a cause for post-operative pyrexia. So in the UK, I don't know if this is widely used internationally, but we have a way of remembering treatment for sepsis as sepsis 6. So these were really drummed into us as medical students, was repeated a lot, and has been one of the most helpful things that I learned as a medical student, to be able to empower me in my own practice as a doctor. So it's about giving 3 things and taking 3 things, and that makes up your sepsis 6. So we give oxygen, so you give 15 litres through a non-rebreathe mask as a sort of resuscitation, and then you titrate the oxygen down as required from there. You give IV fluids, so usually we start with a 500 ml to a litre bolus, depending on the extent of someone's hypotension or septic shock. And then afterwards we can go on to maintenance fluids as required. The third thing we give is antibiotics. So in the UK, each hospital has a different guideline as to what antibiotics to use empirically. And so we have basically a guidance of a broad spectrum antibiotic to use for someone where we don't yet know what the source and the sensitivities of the infection is. And then the 3 things you take, one is blood cultures. Two is urine output. So it's really important to catheterize these people, or if not possible to catheterize them, then make sure that the team looking after them get a really good input output monitoring, monitor their urine volumes and write it down. And it's important that we have sufficient volume of urine coming to make sure we're keeping an eye on whether people are dehydrated. And the third thing that we take is a lactate, which in the UK we take them from a blood gas. And then also routine bloods when you're taking bloods anyway. You want to look at a full blood count. You want to look at CRP. You want to look at the U&E, so their kidney function, their liver function, and then anything else that you might specifically be worried about depending on the surgeries they've had. So in anyone who's unstable unstable with pyrexia, which is a fever, are above 37.5 degrees Celsius after an operation, we have to think of sepsis. And you'll never go wrong treating with these 6 things, even if it turns out they don't have sepsis. It's a life-saving treatment, so it's really important to think about this, about the timing of post-operative pyrexia and how that can help us to delineate the different causes. So if someone has a fever in days 1 to 2 after surgery, we may think that this is a body's routine response to surgery. And often, because surgery is such a stress on the body, a fever in the first or second day after surgery can just be the body's normal response. But because it's also a sign of infection, we need to rule that out before we call it a routine response to surgery. So in the first day 1 to 2, we consider a respiratory source. Day 3 to 5, we still keep considering respiratory source. So listen to the chest, potentially get a chest x-ray to have a look at the lungs. And I'll carry on. So we were talking about the timing of post-operative fever and how we can use the timing of when the fever has come to think about what might be the cause. So early fevers, we think of the chest. It might be the body's routine reaction to a surgery, but we need to be sure it's not an infection before we say it's a routine reaction. In day 3 to 5, we also consider a urinary tract infection. So doing a simple urine dip can be really helpful. And then potentially urine cultures if the urine dip comes up positive. Then day 5 to 7, we consider a surgical site infection or an abscess or collection formation. So that's when you'd want to do a really close examination of the wound, look for any redness or swelling around the wound and any sort of disproportionate pain there. And then obviously any day post-operatively, we always need to think about the lines that we've put into patients, cannulas, central lines. And of course, if people have got catheters and things in place, these can all be a source of infection. Other causes of infection fever post-operatively. So iatrogenic, which means that we've caused it as the doctors. This might include drug-induced reactions or from a transfusion reaction if someone's received a blood transfusion. Venous thromboembolism, which is what I spoke about before. VTE can rarely cause a low-grade fever without any other real clinical features. That's when we really want to think about doing an examination of someone's calves, making sure they don't have any redness or tenderness unilaterally. And then, of course, if we put prosthetic implants into people's bodies during surgeries, for example, after an abdominal aortic aneurysm repair, where we put in a prosthetics, then low-grade fevers might be evident as a normal reaction to the prosthetic, but it can also be a sign of prosthetic infection. So it's really important to keep on top of and close monitoring of these patients. And then lastly, we can have a pyrexia of unknown origin. But beforehand, we need to rule out all of the infectious causes before we can call it that. So when assessing someone with post-operative pyrexia, we always do an A to E systems assessment. So if you guys have been taught A to E assessments before, I think someone's raised their hand. Did they want to ask a question?
No, we don't have any question for now. You can continue.
I'll carry on. So the A to E assessment just someone put in the chat if you've never heard of this before, and I'll go into it in more detail. But in the UK anyway, it's a big focus for medical students as a way to assess acutely unwell patients. So I won't go into it in too much detail because of the time constraints, but I'm happy to go into it at the end if it's unclear to you guys. Doing a detailed systems inquiry into the different systems, so asking someone if they've got any new cough, any chest pain when they're breathing. Those can make you think of a respiratory cause of pyrexia. Ask them if they have any pain or foul-smelling urine. That can make you think of UTIs. Ask them if they have any diarrhea or constipation. That can make you think of bowel sources. And then you'd want to do a generic septic screen. So that includes doing routine bloods, so looking for your infection markers. You can send cultures as well, look at the liver function, the renal function. You can do a urine dipstick, as I mentioned. This is a really quick and easy bedside test to check if someone has any markers of infection in their urine. You send off cultures, so you can culture the blood, the urine sample that you've got, the sputum if you suspect a respiratory cause, and you can also send swab cultures of the wound itself if there's any suspicion of infection there. And then lastly, you can assess them with imaging as well. So mostly in the UK, we start with a chest x-ray for people with post-operative pyrexia because pneumonia and atelectasis, infections in the lungs, are the most common. You can also consider specific imaging, for example, a CT of the abdomen if they've just had abdominal surgery. And these can be guided by the senior surgical team. And then the management. So as I said, sepsis 6 is where we always start. So those give 3 and take 3, that's just the safest thing to do with any patient you're worried about an infection. And it will really save people's lives. Empirical treatment with antibiotics. So that's part of the sepsis 6. And then if the patient's still not improving with all of this other management, then we can consider non-infective causes. So we can consider pyrexia of unknown origin as a diagnosis, but it's important to rule out infection first. So the next thing I'm going to talk about is hemorrhage. I mentioned it a bit at the start. There's a few different categories of hemorrhage. There's primary hemorrhage, which happens at the time of the operation. Reactionary hemorrhage, which happens within 24 hours of the operation, and then secondary hemorrhage, which usually happens between day 10 and 14 after an operation. And secondary hemorrhage is generally because of some sort of infection that was caused from the operation, leading to degradation of the blood vessels, which then leads to hemorrhage. So hemorrhage is a really, really important thing for us to recognise on the wards. And so there's some clear clinical features we can look out for this. This goes for any hemorrhage, not just post-operative hemorrhage. But obviously in this instance, we're thinking about people who've recently had an operation. So we want to look out for their observations. So are they tachycardic? Do they have a raised respiratory rate? Do they have hypotension, a low blood pressure? Are they feeling dizzy, seeming agitated and confused? And again, the urine output, which is so, so important for us to look at after an operation, is that decreased? The important thing to note with hypotension, so low blood pressure, in medical school, we were always taught to look for low blood pressure as a sign of shock. And whilst that is a really good marker of shock, it's often quite a late sign. By the time someone's blood pressure drops, they've usually lost about 1.5 to 2 litres of blood. And by that point, things are getting quite urgent. So someone can be shocked and be having a hemorrhage and can maintain their blood pressure, particularly when people are young and have really good vasoconstriction. They can maintain a good blood pressure with significant blood loss. So it's important to remember that. And when we're assessing our patients, our post-operative patients, it's important to really thoroughly expose them. So make sure you're looking all over the patient, all around the bed for signs of bleeding, bruising, discoloration. We want to systemically palpate the surgical area. So if you want to know what type of surgery they had, palpate for swelling, look very thoroughly for discoloration, palpate, and if they're disproportionately tender, more than you'd expect for someone who is a few days after their operation, then think of something going on there. And then if someone's had abdominal surgery, you want to look for signs of peritonism. And then, of course, you want to look at their observations. Like I mentioned before, look for tachycardia, respiratory rate, and look at their blood pressure as a bit more of a late stage sign. So this next slide is on the management of hemorrhage. I've split this into junior and senior. I'm not sure exactly how it works internationally, but in the UK as juniors, we manage people on the wards. But if people are getting very sick, and there's like certain things that we can't do as juniors, that's when we get our seniors involved. So if you've ever got a suspicion that one of your patients is becoming very sick, it's important to inform a senior early so that they're aware. And it's really important for you to say to them, I think they may be having a hemorrhage, and to say that word, because you have a lot of power as a junior. You know the patients really well. You watch their observations over a long period of time. So if you have a feeling that there may be something going wrong, you've got you should feel really empowered to highlight this to your seniors. So again, as a junior, we can always do the A to E approach. And again, as I said, if you've not come across this before, we can go through it at the end. Take a blood gas sample. This is just a really quick and easy way. You can run it in a machine instantly. It's a really quick and easy way of seeing their hemoglobin level, their electrolytes, and their lactate. These are really key things that we look for in people. If their hemoglobin is dropping really significantly, then that's obviously a very big sign of a hemorrhage. But it's important to bear in mind that post-operatively, usually some blood loss during an operation is normal. And so it's important to interpret it in context of the operation that they've had. Another thing we can do as juniors is make sure they've got good IV access. So put in ideally 2 wide bore cannulas, because this will allow for rapid fluid resuscitation. Another really helpful thing for what we can do to prepare for when our seniors get there is read the operation notes. See whether there was any blood vessel damage or any complications that happened during the operation that might hint at what you're dealing with now. See if it was a particularly dirty examination, a particularly rushed one for whatever reason. It's really, really useful to see what notes have been made. And then, of course, as with any hemorrhage, if the bleeding site is visible, direct pressure is a really good treatment. Unfortunately, generally with our post-operative patients, the hemorrhage is internal, and so we can't see the bleeding site. But it's really important to think about, if you can see a bleeding site, direct pressure is really, really good for achieving hemostasis. And then, of course, close monitoring of the patient whilst you're waiting for your senior to come. These are all things that we can do, even as medical students, junior doctors, anyone on the ward, and they can really save people's lives. Then things that we have senior input to help with is considering imaging. Potentially CTs of people's abdomens can help us see if there's any collections or signs of blood collecting. Considering a blood transfusion. In the UK, we have a marker. If the hemoglobin level is below 70, we always transfuse. I'm not sure if that's the same internationally. And in the UK, we have a major hemorrhage protocol that we transfuse people with red blood cells, platelets, and fresh frozen plasma as part of this protocol if their hemoglobin is below 70. And then possible reoperation. That's something that a senior will decide. As juniors, we don't do the surgeries. But if a hemorrhage is very significant post-operatively, then it might be that the patient needs to go back to theatre to have it repaired. So the last couple of things I'm going to talk about are slightly less major, but are very common and can cause significant distress for our patients. So this third thing is post-operative nausea and vomiting. This is a really distressing symptom for patients, and it's really common. It occurs in 20 to 30% of patients post-operatively, and it has a range of causes, but most of them are things that we've done iatrogenically as the doctors. So it's really important to be aware of, and it makes a huge difference to our patients if we can help them manage this. So there's a few different principles for managing it. So we treat it with antiemetics. There's a range of different drugs we can give people depending on the causes of their nausea. We if someone, for example, has had abdominal surgery and might have an ileus, we can consider decompressing with an NG tube, which is again something that we can do as juniors. If you put in an NG tube through the nose into the stomach and leave that on free drainage, then that can be quite an instant relief of nausea for our patients, and can make them feel a lot better. And we can try and prevent post-operative nausea and vomiting by providing people with adequate analgesia, so enough pain relief, and adequate fluid administration, because when people become dehydrated, they often feel quite nauseous. Just thinking about analgesia for post-operative patients, in the UK, generally, we tend to give people opioids, like morphine and things, to manage pain post-operatively. But it's important to remember that opioids themselves can actually cause nausea. So we might not necessarily be helping the problem. And generally, the most effective antiemetic drug for opioid-induced nausea is ondansetron, and that's what we tend to use in our post-operative patients as an antiemetic of choice. But I'm not sure if you have local guidelines on that. And then another post-operative complication that is pretty common is delirium. Again, this can be really distressing for patients and their families, as well as the staff that are looking after them, because it can cause patients to become quite disruptive. And it's something that's actually quite predictable and preventable, and especially something that as juniors we can make a big difference for patients in terms of keeping them comfortable. So it's a really satisfying problem to be aware of, because we can really help. So delirium is an acute confusional state characterized by disturbed consciousness and reduced cognitive function. It occurs in 15% of elderly patients following surgery. In the UK, we have a rapidly aging population, and so the majority of people who are undergoing surgery are classified as elderly patients. So this is something we see all the time on the wards here. So risk factors for delirium: so age over 65 years, people with multiple comorbidities that existed before their surgeries. Again, this is really, really common in our patient cohort in the UK. Underlying dementia, so obviously if someone's already got dementia before going into the operation, the big stress of the operation, the change in environment, can obviously put people at very high risk of delirium. Renal impairment that might lead to electrolyte abnormalities is a big risk factor for delirium. Male gender, interestingly, is a risk factor, as well as sensory impairment. So if people can't see or hear very well, it puts them at higher risk for delirium. And causes of delirium: so there's post-operative hypoxia, infection. So this is again where it's really important to look at their observations. This ties really nicely into our post-operative fever teaching, where we want to think about septic screens, urine dips, looking for UTIs, chest x-rays, and listening to the chest with our stethoscopes, looking for respiratory tract infections. Then we've got drug-induced or drug withdrawal. So if people are addicted to alcohol or benzodiazepines, then after their operation, if they're not getting access to those drugs that they may have had at home, withdrawal from that can cause delirium. But equally, the drugs we give people, morphine being one of them, can actually cause delirium. And that's important to be aware of. Dehydration or pain can also cause delirium. And these are things that as junior doctors, we can treat. We can stop people becoming dehydrated with adequate fluids and encouraging oral fluid intake. And we can manage people's pain with adequate analgesia. Constipation and urinary retention, again, can both cause delirium. So it's really important to have a monitor of people's bowel movements after surgery. So get them to make sure the team looking after them keeps accurate charts. And again, monitoring urinary output, as I've mentioned a few times, is so important in our post-operative patients. And if you think you've got a patient with urinary retention, we can do bladder scans, which are non-invasive ultrasound scans of the bladder, looking at what volume of urine is inside. And if it's an increased volume, then we can catheterize them, and that instantly relieves the urinary retention. And then electrolyte abnormalities. So as I mentioned before, electrolyte abnormalities such as sodium, calcium, potassium, these can all cause delirium. And it's really useful to get a set of bloods just looking at the electrolytes to see whether this is the cause. So in assessment of delirium, so you look for risk factors, the ones that I've mentioned before, and you perform something called a confusion screen. This is basically involves doing a set of bloods, as I mentioned. So you want to look at people's electrolytes. In the UK, we also tend to look at people's B12 and folate levels. These are two things that can cause delirium if they're low, and it's often incidentally picked up in people who come in for surgeries. You can perform chest X-ray looking for respiratory tract infections or any other imaging. Sometimes a CT head is indicated for people with delirium as part of the confusion screen, but this isn't indicated in all patients. But particularly useful to think about if they've never been confused before, and if they might have had a fall that it was unwitnessed, or someone's seen them hit their head. As with all of our post-operative complications, we always want to think about infection. Think about our sepsis 6, and infection is a really important cause of delirium. A collateral history is really useful. So speak to the nurses who might know the patients for a longer time. Speak to the patient's family, their wives, brothers, daughters, sisters. They will all know what the patient has been like for the last months and years. And it can be really, really useful to get a history from them as to what the patient was like before they came into hospital and before we as doctors knew them, because that gives you a really good idea as to how much they've changed from what they might have been like before. And then a drug history. So again, thinking about if people use alcohol very regularly or take benzodiazepines, then this delirium could be a result of their withdrawal. And it's really important for us to be aware of, and is really easy for us to miss. So managing delirium. So if you've identified a cause, then treat it. So if they've got an infection, we treat the infection. If it's a result of a drug withdrawal, then we treat the drug withdrawal. It's important to nurse them and care for them in an appropriate environment. So if someone's got hearing impairment or can't see very well, it's important to make sure they have their glasses and their hearing aids so that they can be aware of what's going on around them. Giving people access to clocks or ways to tell the time, ways to tell what day of the week it is, can really help to orientate them and make things seem slightly more normal. Obviously, a hospital is a very abnormal environment for most people. Encouraging oral fluid intake prevents dehydration, also makes patients feel empowered about their own care. Providing adequate analgesia, again, this comes up. This is something that we can do as juniors, making sure our patients aren't in pain. Monitor their bowels and their urine output. That's really, really important for any post-operative patients and can be a really good indicator as to things going wrong. And promote a regular sleeping pattern. This is easier said than done in most hospital environments that are very noisy throughout the night. But if you can, keep lights low and noise at minimum overnight for patients so that they can get some sort of sleep overnight. This is particularly helpful in our patients who are at risk of delirium and can prevent them from having delirium. And that comes to the end of my lecture. Those are a bit of a quick tour of the main post-operative complications. I hope that was useful. I'll stop sharing my screen. Does anyone have any questions or anything that wasn't clear